that's fine. I can edit that.
Okay.
So this has been this has been a sad issue there. And the other thing that everybody seems to think is you can treat really sick people with a cookbook. Everybody's the same, and you don't need to have doctors anymore. You just prescribe something, and everybody's the same. And then the other idea is that there are going to always be some people who need high dose opioids. I don't care what we do. We're working on a lot of new things right now, and we're making a lot of headway in bringing opioid dosages down. But we'll always need some people to be on high opioid dosages.
What are the factors, so that people out there that don't know, what are the factors, kind of simply, for someone like me that needs high dose opiates? What are some of those things?
At this point in time, the only way out of this is that families and patients are going to have to let the people in the federal government know that they are not solving the problem. They're worried too much over here about, frankly, people who misuse drugs and overdose and die, and not enough people who have served our country well and been good members of society who may need some special care. And there needs to be a balance.
Absolutely.
But unfortunately, we in the medical profession don't have a lot of voice anymore because we're represented by groups of doctors and hospitals and pharmacists who really don't like opioid care or even chronic pain care or palliative care. It's been tragic to me to see that we have people say, it doesn't make any difference if you're going to die in a month or two, you ought to cut your opioid dosage down.
Wow.
We're hearing people say you should be able to go ahead and have major surgery and not take an opioid. These things are ludicrous, and we're going to have some balance brought in. I'm optimistic, but I'm only optimistic relative to how much education we can do, and this also includes elected officials, bureaucrats, and other people. The federal government's come into California and fundamentally said our Patient's Bill of Rights doesn't count. People no longer have a right to non-standard treatment. And these things are going to have to be resolved. But I can't emphasize enough that in the end, the pressure and the lobbying that families and patients do is going to make the difference.
Okay. How, to tell people out there, how are you doing with this, and what can we do to help you, and then obviously what we can do to talk to our government to advocate for ourselves?
The way to help me is real simple, and that is to let people know that I'm no different than the days of Hippocrates. We've always had doctors who were older, experienced, become the experts in their field for a few years. I'm at the top. Now, I'm not going to be around a long time. And I take the cases that the other doctors don't want to take, or can't take, or don't have the experience to take. And they're going to have to get over something. You're not going to make robots into doctors. You're going to have doctors like me who take the difficult case, the case that's failed everything else. It's a concept that is not new. But somehow they believe that doctors who treat pain and the problems that cause pain should be able to pick up the latest current therapy and just prescribe what's in there and make it do. Well, if that was the case, I wouldn't have a practice, because I only take people who have failed other things. You know, very interestingly, people who come here take an average of 11 drugs and have been to see an average of 6 or 7 pain physicians, including universities, high-powered facilities, and there's nothing new about that either. Those facilities are doing a good job. It's just that there has to be what's called, or at least in my trade, not a new term, nothing new, but you're always going to have the doctor of last resort. That's me. And all of a sudden, I've got people judging what I do who don't treat what I do. Because here's the other thing that the public's got to know. You're going to have what we've always called peer review. You want to judge me? Get somebody who does what I do. Get somebody who's willing to take a case or is smart enough and been around long enough as me for me to consult. Don't give me somebody who's never treated arachnoiditis or post-viral encephalopathy or RSD, and people who are going to die in a couple of months who just need a good hand to hold. In other words, let's get real. We're going to judge doctors. Let's have peer review. Let's understand that we're going to have outliers. We not only need compassion, but we need science, and you're going to have a balance. And this fear of opioids is overblown. People who know what they do, like myself, we don't have overdoses. Because let me tell you something that's different about my investigation. Now, a lot of it has to do with false fraudulent claims, because I spoke and did some work for a company called Insys a few years ago. But the fact of the matter is, I use high dosages of opioids, but I use low dosages. I'm working to find opioid substitutes more than anybody else. But here's the thing. I don't have any overdoses. I don't have any reports of diversion. I don't have anybody who's abusing drugs. And so you might ask the question, why not? I want to give you a simple answer. I know what I'm doing. There's a way to prescribe these drugs. There's a way to handle patients and accept patients and select patients. But that's for an expert physician. And these doctors that are getting overdoses, this diversion out on the streets, these are inexperienced doctors who don't know what they're doing. They could learn, and I fault a lot of people these days that they haven't educated doctors like they should. And I'm not talking about medical schools. I'm talking about doctors in practice. I've gone to so many courses in which they are taught the wrong information about how to prescribe opioids and about how to take care of the severe pain problems. And I'll leave you with one last thing. This field is in a profound change right now, and I'll tell you what it is. 10 years ago, we didn't know why exactly people were in terrible pain. They had back pain, head pain, leg pain, arm pain, stomach pain, but we didn't know why. But in the last 4 or 5 years, we have figured out the names and the diseases that cause this serious pain. We are switching from treating pain over to a disease-specific climate. 5 years from now, I don't think we'll have pain clinics. I think we'll have clinics for reflex sympathetic dystrophy. We'll have clinics for Ehlers-Danlos syndrome. We'll have clinics for arachnoiditis, clinics for RSD. But we're not going to have standard pain clinics because we know what the underlying cause is now. And a lot of people don't want to admit that. They don't want to admit that we know about viral infections. We know about neuroinflammation. We know about neurohormones. We can treat these things. And they're very treatable, and people can get a lot of help. And we're using fewer and fewer opioids. That's the other thing people don't realize. Opioid prescribing is dropping like a rock. And for example, let me say something that no one wants to hear. Long-acting opioids should go right out the windows. So should probably epidural injections. So should a lot of this surgery. A lot of this stuff is just expensive, things that we don't need today. We've got options. I'll leave you with that. We're in a big change for the betterment of everybody. But again, you families out there that are hearing this, you patients are going to have to put the pressure on it because you're not going to have me around and other doctors of my generation and my ilk. You're going to have to create new ones, but that's going to take pressure and education from you. I think if the best thing about these whole investigations is people are waking up, and they need to. Otherwise, we've got people out here dying and suffering that don't need to suffer or die.
Absolutely. Thank you, Dr. Tennant. Andrew, CDC, DEA, no more about us without us.
I like that.